Wow, thank you very much, Robin. So when I was trying to come out with a title, of course, I started thinking about the anniversary that we're celebrating this year. And so I decided to title it The 30 Years of Accomplishment, and Where Do We Go From Here? We all know that this all started 30 years ago in 1983. I think Dr. Ed Mason, which is known by many of us as the father of obesity surgery, he had the clever idea to found the ASBS at that time in 1983. Now, Dr. Ed Mason, actually, he started way before 1983 to work in bariatric surgery. Back in the 60s, he decided to use a surgery that was designed for ulcer disease and to use it for the treatment of severely obese patients. He also was clever enough to come out with another surgery, completely opposite. Didn't have any malabsorption, just restriction, as we know, the BBG. But Dr. Mason actually decided to start getting together. A lot of the past presidents that we have here sitting with us were in those groups, original groups, small meetings in the University of Iowa. That's where Dr. Mason was working. And in 1976, they started getting those meetings together. And based on those meetings, that's when in 1983, the ASBS was founded. Dr. Mason also was way ahead of the times. You know, he wanted to have a registry of cases that could document outcomes. And actually, way back in 1986, you know how much we're struggling now with our databases. He developed a national that eventually converted to an international bariatric surgery registry. Not only that, a lot of the surgeons that were on those founding members of the ASBS are the ones that actually developed the techniques that now we're using. This is Dr. Kuzma. He was one of the original members, and he invented the adjustable gastric banding that was used in open surgery and now was the predecessor of the laparoscopic technique. Dr. Doug Hess used a different technique to change the scoping arrow procedure to the duodenal switch. Dr. Alan Whitgrove, one of our past presidents, used the laparoscopic technique to do the first laparoscopic gastric bypass. Dr. Michel Gagnier, another inventor and member of our society, did the first laparoscopic duodenal switch, used the sleeve gastrectomy as a first stage technique for the first time. Now, all these inventors of our techniques in the 90s and established the treatment laparoscopically allow for us in the 2000s to start growing the numbers and start doing more cases. And this is what we've seen since then. So when you look at the growth of the membership of the ASMBS, look at the numbers in the 90s, they were pretty flat. But in the 2000s, they start growing, along with all the volume and the number of procedures based on those techniques that were created. I really wanted to thank, the membership committee led by Sam Somstein and the international committee now led by Samer Matar for all the work that they've done really to increase the membership of our society. I can tell you that right now we have close to over 4,100 members. Over 2,300 members are surgeons, and about 1,700 members are integrated health. But we also are a global society. We're represented in 52 countries. So this is all great. Now, where do I fit on this growth? So I started doing bariatric surgery in the latest part of the 90s. In the 98, I was doing cases. And that's the time in which I joined the society in the 2000. And in order for me to start growing and developing my techniques, I had to learn from all these leaders. And I wanted to use a few minutes to really recognize my mentors that really helped me to develop the techniques that I know. And some of them are here in the room, so thank you for all the help. This is Dr. Rodolfo Sanchez and Roberto Rumbal from Mexico. That's the first exposure that I had to the gastric banding. George Fielding, that helped me to understand the pars flaccida, and Paul O'Brien, that really helped me to understand the management of the band. I want to thank Phil Showers here, where he opened his doors to his clinic, not only to me, but to all my staff, This is some of my stuff there. To come up to learn about the gastric bypass. My dear friend Nathan Sundell, I don't see you. Thank you for all the help, all the traveling that we did, and start doing sleeve gastrectomies in different parts of the world, and then you helped me to start the program in my area. My friends internationals that really opened the door also to their clinics and allowed me to learn some investigational techniques that I wanted to use on IRB procedures. So thank you, Almino and Manuel. But I also wanted to thank one of our past presidents, Walter Porris. He really opened the door to me to the ASMBS. Like any other surgeon, I joined the ASMBS because it was a society on the field that I was attracted to practice. And he, after I did a presentation one year, 2003, in a bariatric meeting, he came and approached me and told me, Jaime, I really enjoy your presentation. I really think that that's a good data, and I want you to come and present some of your data to the first ASBS consensus meeting, which indeed happened in 2004. So thanks to Walter, I really got interested and attracted and got involved into the leadership of the ASMBS. Got exposed to talk to all the leaders and got exposed to the work. After that, I was invited to participate in review committees and many committees of the ASMBS, and that really opened the door for me to grow in the ASMBS. So thank you, Walter. So now let's move on to what has happened over this last, which many of the past presidents call it a year term, and I just had the opportunity to make it 17 months. They've been interesting. There's been some issues. There's been some opportunities. And I just want to quote about 2 or 3 quotes that I heard. I received so many comments from so many people, and I really wanted to thank everybody for their comments and calls and communications. But I'm going to quote some few ones just to give you an idea of the kind of things that I was getting through email that really motivate me to keep trying to solve and use this as an opportunity. So Alan Whitgrove sent me an email, and I'm just extracting some portion of it. You must feel like one of those bears at the shooting gallery that gets hit and spins around and then gets hit again. Sound like here? This is a quote from George Ann Mallory, our executive director. Just when things were almost starting to settle down a little, wham, quite the presidential year. Make that year and a half. The one that I enjoy, again, a lot is from Walter Porris. So he wrote a long email extracting a few words of that, and he said that the word crisis, quote unquote, in Chinese also means opportunity. So in all the turmoil, just do what's best for the patient. And that's what really we were trying to do. Trying to extract out of all the issues and trying to do what we thought was the best for the patient. So now the ASMBS in 2013, 30 years later, we really are presenting it to you with a new face. Just this meeting is the first new, different meeting that we have. It's a great event. It's been successful. We have now the opportunity to join the Obesity Society and join many other small groups that allow us to establish a better connection and relationship with everybody. So we also have a new way to communicate with our members. We have a new news magazine, Connect. And what we're trying to do, we work a lot in the Executive Council to really transmit the message, and we're still working on getting better transmission to the message of what we're trying to do and the work that we're doing in the leadership. We also have new interaction with the state chapters. The state chapters were growing. We're growing very independent. So really during this year, we tried to align all the president chapters and start working under the big umbrella of the ASMBS. So now the ASMBS actually is supporting the chapters with administrative support, with CME support, with DO support, with web support, and even they all have a very similar logo that represents the ASMBS. We also present the ASMBS with new accreditation standards that finally they're finalized and approved, and they will be implemented early next year. We also have a new website. And the goal of having a new website is to really, besides making it work better, and besides having better menus and better links, to have a portal for the public. We wanted the public to come to us, to the website, and then learn from us what we're doing and learn what's the best thing for them to do. We're also going to have a new phone app for this website. And I want to announce to you that we've been working also during this year, and I wanted to thank really Ninh Nguyen for this, on a new textbook. This is going to be the first of a kind. It's going to be a major book, 2 volumes, 55 chapters, more than 80 authors. And this book is probably going to be available by a spring event next year, so look forward for that. Now, from all the work that we've been doing over this last year and a half, and from all the things that I have learned from the ASMBS, I do have some recommendations and suggestions and statements that I can make to the ASMBS for the future. I do think that the ASMBS, number one, needs to fully embrace training and education of metabolic and bariatric surgery at all levels. At all levels, what I mean is that we really are very focused on our surgeons and fellows, but we really need to develop curriculums for medical students, residents, and other specialties. We do have already a presence on the American Board of Surgery. Ninh Nguyen represents us there. We already have a fellowship certification, and we already have the best educational offerings in bariatric surgery. But we really need to start taking it further to start looking at all the levels so they can understand what we're doing. But also we need to start thinking on the future. Is our field ready for a board certification? And I do think, even though this is a very long-term plan, I do think that we have a field that deserves their own specialty certification. That's going to be tricky. That's going to be controversial. And I can tell you that we need to do a survey to the members. I think we need to explain a grandfathering process. But I do think that we also need to look for endorsement from the societies, and it's just very difficult to get that. Number two, I do think that the ASMBS needs to continue to be on the leadership of leading the accreditation standards. We've been doing that, and I think we need to continue to do that. Because accreditation really has improved safety and outcomes, really has been the vehicle for data acquisitions. We would never have that data collection that we have today without the accreditation. It has increased access. It has increased hospital support to bariatric programs. With the partnership with the American College of Surgeons, we're really shown now as a single accredited body for all payers. The insurance have followed our standards over time. They follow the 125 number. And so we really need to keep letting them know what we believe is the right number based on the best evidence that we have. And it really has helped to identify those practices that do a good job in bariatric surgery. We've seen all these slides. Mortality has decreased. We've seen all the slides about how Medicare, NCD, really did affect the decrease in mortality. The argument about access. I mean, really, there's more Medicare cases that have been done today as opposed to before the accreditation. We also know that high-volume centers have less morbidity, less length of stay, less cost, and less mortality. And even when we divided the high-volume centers in between accredited and unaccredited centers, we know that the accredited centers have, even though they may have similar morbidity, the accredited centers have 3 times less mortality. The numbers are small, but it's still significant for that patient that dies. And so 3 times the difference on mortality is huge. So the ability to rescue patients potentially could be better in an accredited center. Now, when I embarked and discussing this issue because of the CMS proposal to drop accreditation, I didn't want it to go alone. I did believe in accreditation, but I asked all the leadership, are we going to support this? And I can tell you that the whole leadership, almost in its entirety, supported accreditation. And then I said, well, let's ask the members. Because some of the leaders say, well, maybe things are going to be different, maybe we don't know. Let's ask the members. And this is what we got from the members. 75% of the surgeons support accreditation, and 87% of the integrated health support accreditation. This was very important for me because I really was going to take an action and a big fight on something that I needed to know if there was support or not. And there was. But as you can see, 25% of the surgeons do not support accreditation. We also look at the CMS public comments. And out of those comments, on the latest round of comments, 483, we have 80% of the comments support accreditation. We also ask the professional societies if they either support accreditation with us or independently. And as you can see from this, we have the American College of Surgeons, we have TOS, we have the ASBP, we have SAGES, we have the American Association of Clinical Endocrinologists, we have the dietitians as well. So they all supported accreditation. Now, accreditation is going to enable us to measure many things in the process of quality. Those are the three big quality measures that we were looking: structure, the hospital infrastructure; process, how we take care of patients; and the outcomes. The outcomes haven't been measured on the previous centers of excellence, and that's what we're after, to get good data, to start measuring outcomes. Outcome measures really need good data, good clinical data. It is very, very difficult to obtain, but we're getting there. We have data collectors, we have better data points. We still have the issue of poor follow-up, risk adjustment is going to come up. So all those things are going to be important for us. But to me, program accreditation is a venue to improve quality, and it should not be seen as a restriction of access. Now, I want to be fair, and the arguments that I hear during this year against accreditations were the following. Many complain that it is an administrative burden, and it is, but it is worse, and it could be worse if we allow the insurance companies to run this accreditation process. Right now, their hospitals are completing 4 different applications. In those applications, the goal is to get them universally into one process. It is difficult to achieve because of the case volume. Well, I can tell you that now with the new volume standards, hopefully it's going to be easier, the process. There's restriction of access, and I already showed you that really the restriction of access, especially on Medicare patients, hasn't changed. But by increasing the number of centers, we should be able to improve access. And it's not proven and not needed, which I already showed you the evidence that is really getting some evidence that is a beneficial thing. Now, we also have the support from the private insurance companies, and as you know, if we didn't do anything among ourselves about accreditation, all these companies would have done their own standards and their own process. And just to give you an idea, just 3 weeks ago, Blue Cross Blue Shield told us, to the leadership, that after participating on a site inspection with us and seeing the detail that we go through, they are going to only invite MBS AQIP centers to their centers of distinction process. So this is just one part of the things. This is just one part of the things that we really think that all the work that we're doing is just transmitted back to the insurance companies. Now, I have also created a task force, which is an insurance communication task force, that is going to continue to have that conversation with all the insurance to keep them aligned with us. I don't think it's enough to talk with them one time and then walk away. But the next year, they'll forget about us, and they'll do whatever they want. So I do think that this is going to help us to kind of change that attitude. We also need to learn a lot from Michigan. They've done this for many years. They've done quality improvement. They've done collaboratives. And I do think that we need to find a way to work with those Michigan programs to include them into the MBS AQIP. I wanted to thank all the members of our leadership that work for the MBS AQ committees. I know that was a lot of work. I know there was a lot of pressure. I know that probably I credit a lot of pressure on you to kind of get this work done faster. I apologize for the pressure, but I also wanted to thank you for responding as good as you have done. And I think the future for the SMBS is to also use our own committees. Our patient safety committee needs to develop and provide resources to hospitals and practices to maintain and improve patient safety. Number 3, I think the SMBS needs to use the data for quality improvement. And I think with better data that we have, we can get that information and we can develop that quality. We learn again, this is Michigan. And if we intervene at the right time, then we can decrease that rate of complications. So I wanted to also thank John Morton for developing a lot of the quality initiatives that we're going to start. Actually, tomorrow, we have the first national quality improvement program that is going to be rolled out to many programs that are participating on the MBS AQIP that can be used to one of those quality improvement programs in the future. Number 4, I think the ASMBS need to continue to collaborate at all levels. Collaboration is going to allow us to improve and maintain quality, and we can use with all those regional collaboratives, we can use it national, and we can use it worldwide. The ASMBS state chapters has done a tremendous work to increase our state chapters. Now we're represented in 32 states and Canada from 27 chapters. And I think that support, and I want to thank Michael Nussbaum and Lloyd Stegman, the past chair of the state chapters committee, because they really have done a tremendous job to improve that. These state chapters are the ones that are going to allow us to do a lot of these local and regional collaboratives. But we also need to continue our political advocacy. You know that the ASMBS sponsored this year the second meeting in Washington with more than 20 groups that advocate in DC for obesity treatment and coverage. We did sponsor that. We did hold those sessions. A lot of the work has been done through the Access of Care Committee, and I want to thank Wayne English as well for that. But we need to continue to be the leaders on that, and they are willing to collaborate with us. We also are part of a collaboration among GI surgical societies. We're a member of a small group together with SAGES, SSAT, the colorectal surgeons, the hepatopancreatic biliary surgeons, and IPEG. And we're working together in collaboration. This has allowed us easier endorsement for our credentialing guidelines, easier support for our sleeve and accreditation efforts with Medicare, and we also have helped them to endorse like resident curriculums for an endoscopic training during residency. I also want to announce to you that the ASMBS for the first time is going to have a seat in the AMA House of Delegates next year. And this is thanks to us trying to talk with the AMA leadership. We met the quota for members that are members of the AMA. But I do think, even though we may disagree with some of the things that the AMA come up with, we need to have a voice. And we have never had a voice in the AMA before. We have had a voice through somebody else and some other societies, but we haven't had one. Number 5, I think the ASMBS needs to use technology to the fullest extent. We are learning that. You know, if you have used your phone app for this meeting, I thought it was great. And I think we need to continue to use this kind of iPhone or phone applications. I think we need to use the web and social media better because people, that's where they're getting the information. And I think the public education portal is going to be a good venue to release that information to the public. I wanted to thank again the Communications Committee and Public Education Committee for developing a lot of this effort. But we also need to take technology, and talking with some members of the leadership, technology for distant learning, for remote training, for virtual collaboration. Those things, I think, are the next step for us to spread out our quality initiatives and to spread out our educational offering. Number 6, I do think that the ASMBS needs to pursue that universal access to care that we really needed. This is what we've been fighting the whole time. And I do think that this quality program that we have is going to be the venue to start that process of universal coverage. If those 4 major payers align with us in a universal application and start getting to that point, I think we're going to be there. But we need to demonstrate to them that we have quality, that we cost less, and then we can improve the access. Also using this type of maps. This map in 2011 had no coverage for sleep in Medicare. This is thanks to the effort of the leadership. John Morton was leading all the efforts to the Access of Care Committee at that time. And now every single state has some kind of coverage for Medicare patients on sleep. So those are the kind of things that we need to move on. So access and coverage, thanks to Access to Care Committee, Insurance Committee, coding, we need to continue to work on that to improve the access. And we have a very good team of people that really like to go to DC, that really enjoy getting this coverage better. But one thing about universal coverage and universal acceptance is the public message that the ASMBS sent. I get a little bit frustrated with, among us, the members, in the public media, in the public news, we start fighting against each other about techniques, about this is better than the other one. I mean, the public they just need to get one big message, which is what we do is safe and effective. They get confused, and if they get confused, they're going to say, well, first of all, you all get together, and then later on we'll talk about coverage. And so I think it's very important for us to align in one single message. Leave the fights here for these meetings, because these meetings are the best forum for that. Number 7, I do think the world is getting smaller, of course. We have planes. But we really must reach every place. I was talking yesterday with Luigi, the president of IFSO, and we really need to utilize our United Nations Organization in Bariatric Surgery, which is IFSO, to really spread our knowledge. The world demands our education programs. They do believe that our education programs are one of the best available in the world. They want to have access. Not many members internationally or not many surgeons internationally can travel to the United States for that. So we really need to find ways to export not only our education programs, but also our quality initiatives. And I think IFSO could be the best venue to start working more closer with them. We're members. And if you don't know, every single member of the ASMBS is a member of IFSO. And we are a member society of that organization. Number 8, I think the ASMBS needs to embrace research that explains the therapy. And I do think that we're trying to do that. You know, the research committee is really working hard on selecting the best funding through the Foundation for Research and papers that really start trying to explain that mechanism of action. But that's the goal, to really try to find an explanation of what's the best treatment for each patient. That's difficult. That's a difficult answer, and you see all the discussions on how difficult it is to get the right answer. I do think, number 9, that the ASMBS needs to continue to work with the industry to complement the progress and innovation in bariatric surgery. Now, we need to be very careful, of course, because the work with the industry needs to be for innovation, to develop research platforms for new therapies. Research should be separated from sales, and there has to be complete transparency. But the reason that I'm saying that is because if many of these industries, they see that the ASMBS is embracing the support and the research, we can work with them to let them know what is the best research platform that they can do to allow us to determine if a new technique or a new procedure can be validated or not. So the Emerging Technology Committee is really doing a good job right now to analyzing every single innovative technique and device available. Number 10, I do think that the ASMBS needs to continue to be the leader and develop and continue to develop our position statements and guidelines based now on better data that we're going to have. Remember that we're collecting better and better quality data. I do really want to thank Stacy for the tremendous job that he's done during his chair of that Clinical Issues Committee in developing many position statements. And we're going to continue to work on that. In pediatric surgery as well, developing guidelines for pediatric surgery. But there's many more work to do. For example, one of the things that came up during my time as a president is that we've really been struggling on coming up with an answer for revisional surgery. The data is not very good data. The data is all over the place. But insurance companies are already putting their own guidelines. And I think we really need to start setting the pace. So we did develop a revisional surgery task force. And this task force, the goal is to come up with 3 papers. You know, one, we're going to develop a paper, and it's already finalized. And I can announce to you that it's going to be published very soon in SWORD. It's the state of the art of the literature. Basically a systematic review of the literature on revisional surgery and what the ASMBS think is a good statement on the things that we do when we revise a case. The next paper that is going to come up is the state of the access. Because we do have the access all over the place. You've heard insurance companies paying for only one-time procedure lifetime. In the third paper, we're going to look at the data from the databases and then explain to you the growth on revisional surgeries. All of you are doing more revisional surgeries. Finally, I think, and I skipped one slide here because I updated my presentation today, they didn't put it there. But number 11, which is not on the slide, number 11, I do think that we need to get much better much, much better and sending the right message to the public. And this work is already started, and I do think that Nin is going to do a very good job on implementing different ways and different innovative ways of us improving that message so that we can grow the number of patients that have access to surgery. We're still doing less than that 1% of potential candidates for surgery. So finally, I do think that behind every surgeon there is a team. All of us have a big team, and I wanted to use a few minutes to recognize my team. Without my team, I wouldn't be able to do this. Certainly there's not enough time in the day to do the work for the ASMBS and still have a practice. I do have a private practice and work in 2 beautiful hospitals. One of the hospitals is Hamilton Medical Center in Dalton, Georgia, north here of Atlanta. Some of my team is here that work with me. And I also work in a hospital in Chattanooga, Tennessee, Memorial Hospital. I also have a great staff. Brooke, my coordinator, has worked with me for more than 10 years. And so that has allowed me really to, every time that I come to her and tell him, now I do these phone calls, I have to do this research, I have to collect this data. So all these things really have helped me to do what I need to do. But I also wanted to thank this year and a half has been a tremendous work, a lot of phone calls, a lot of review of papers, and all the executive council really has been very responsive. I can tell you that we have a great team of people that really are helping us to get the work done. So this is the executive council. And without the ASMBS staff, we couldn't function. So I really wanted to thank all the ASMBS staff. There are 2 people out of that ASMBS staff that really has worked very close with me, and I wanted to thank them personally, because I know that any past president can tell you, without Georgia, we couldn't do this work, and the society couldn't done really what they've done. And Jenny, she's done a tremendous job just keeping up with all the activities in the small leadership group. I also wanted to use this opportunity to thank 2 of my good friends. As Robin mentioned, we're like the 3 amigos, but I really get to know Nin and John more by working at the ASMBS, but we really have managed to get a small group that really tried to work on every issue and trying to answer and trying to find the best way. So really the work is the whole team, and this small group really have helped me to do my job much easier. So I really wanted to thank Nin and John. I mean, they have traveled with me, they have done a lot of work, and I do think that we're going to have a good continuity on this ASMBS because we have worked together a lot. So thank you very much. And as you know, the most important thanks I have to give it to the people that have tolerated me and not showing up for dinner and making phone calls before the kids go to bed. And my wife asking me, well, who are you talking with at midnight? So it just happened, these 2 good friends, they live in California, I live in Georgia. So for them, 9 p.m. is my midnight, correct? So I have to wait until they finish their cases and they finish their fun life so we can talk at midnight. No, but we really, I really wanted to thank my 2 kids, Alex, come on, Isabel, Alex, ven para acá. So I speak in Spanish with my son so he can understand. Alex, ven. I know. So this is my daughter Isabel, my beautiful wife Heather. No, she has really tolerated me. So thank you very much. It's been really, thank you for the opportunity and the honor to serve you as your president. It's been a pleasure. It's a lot of work, but I have enjoyed. Thank you very much. Look at this. ¿Lo viste?